folks. I'm gonna let in here. Welcome. Thanks for joining us. Admitting. Okay, well, in the interest of time, I'm going to go ahead and get us started here, and folks will continue to join in as we get kicked off. But I want to welcome everyone to part two of Bridging the Gap, delivering equitable health services with people with disabilities. In a moment, I will pass it on to our presenters today, Mackenzie Jones, Meg Ann Tracy, and Erin Blay. I will put in the chat the presenter bios so you can get a little bit more information from them. And we will have an additional presenter joining today, some change due to illness. So I'll let our folks, our presenters today, tell you a little bit more about that. But I'm going to pop this into the chat here, and I'm going to turn it over to Mackenzie Jones. Thanks very much.
Wonderful. Thank you all. My name is Mackenzie Jones. I'm a white woman with short blonde hair and glasses, and I am thrilled to be here. This is part two of our webinar, Bridging the Gap, Delivering Equitable Health Services with People with Disabilities. On November 19th, we had our part one with Isaac Baldry was our guest presenter, and he shared his experience as a person with physical disability, as well as someone who uses augmented communication and his access to healthcare, and how he has learned how to advocate strongly for his needs and his supports, but also still experiences challenges, especially when there is an emergency. So today we're hoping to take that description of what healthcare barriers look like and what he explained as needs for people with disabilities to access accessible, quality, inclusive healthcare, and to talk about how you can move forward to make changes in your public health clinic as well as your healthcare facilities and really any place that you're working or living to make sure that the community is accessible and inclusive for people with disabilities. So with that, I will have my team introduce themselves. We have Erin Bly, and I don't know if you want to do it yourself or.
Oh, yeah, no, I was just waiting. Hi, everyone. I am Erin Bly. I'm the health educator, and I work with Mackenzie at the Montana Department of Health and Human Services. And I work in the Montana Disability and Health Program, as well as the Montana Arthritis and Falls Prevention Programs. Great to be with all of you today.
And we also have Meg Tracy with us.
Good afternoon. My name is Meg Tracy. My pronouns are she, her, and my audio description is that I'm a white middle-aged woman with long brown hair, and I have a Monte Dolac print of Rock Creek behind me. I work at the Rural Institute at the University of Montana, which is one of 68 university centers for excellence in disability education services and research. My academic appointment is in the School of Public and Community Health Sciences, and one of my beloved roles is being able to work on the state disability and health program with the team at DPHHS and partners like Centers for Independent Living. So I'm really glad to be here today.
Thanks, Meg. And due to a last minute change, our next presenter I wanted to introduce is Travis Hoffman.
Hello, I'm Travis Hoffman. I am the policy director at Summit Independent Living. We are headquartered in Missoula. We have offices in Hamilton, Polson, and Kalispell. We are one of 4 centers for independent living across the state of Montana. Our service area is the 7 westernmost counties. I'm also a person living with a disability. So.
Thank you so much, Travis, for joining us last minute. Great. So I will share my slides and we'll start there. And yay, I get to see everyone while I do this. Okay, so If you were here for session one, you got the rundown of who we are, but for those who haven't watched the first part of the webinar, I wanted to give an overview. As Erin said, we're with the Montana Disability and Health Program. We are housed at the Department of Public Health and Human Services within the Chronic Disease Prevention and Health Promotion Bureau. So we are there because we are addressing health and wellness opportunities with and for people with disability, recognizing that everyone has a right to the highest quality of health that they can, that anyone can have, whether they have a disability or not. And so we work across sectors within the public health world. And this program is funded by CDC, and there are 9 other states that are also funded currently. On the screen, I have a map of the United States, and highlighted are the 10 states that are funded, which includes Montana, from west to east, Oregon, Utah, Missouri, Michigan, Ohio, Georgia, New York, New Hampshire, and Massachusetts. And you might ask, what is disability and health? Well, we recognize disability as a community. Disability is a demographic, just like gender, sexual orientation, and uh, it's a group of people that we recognize experience health disparities or differences in health um, due to social factors, as well as health inequities. And those are the differences in health that can be, they're due to, let's see, I just want to make sure I get this right instead of waiting. Due to unfair or unjust practices and stem from a form of injustice or avoidable behavior barriers. So like lack of accessible transportation to get to healthcare or to get to employment. For example, in Helena, we have accessible transportation, but it's only offered on weekdays during work hours. So um, people with disability who need accessible transportation might not be able to get to the social activities or other personal needs like the grocery store during non-working hours, as well as bias among healthcare providers. So our program aims to increase health and wellness opportunities with and for people with disability, and I really emphasize with people with disabilities because we can't do it without full inclusion of people with disability on our advisory board, in planning sessions, with us along the ride for all the projects that we work on. We do this by collecting data, understanding the gaps in data, as well as better understanding what health disparities exist and what are actually priorities for that population. We do this through education such as this, where we're supporting healthcare providers and public health professionals and students and learning more about disability and what they can do to support inclusive, accessible environments, but also education with the Centers for Independent Living, as Travis described, where we are supporting facilitators to implement health and wellness programs with and for people with disabilities as consumers of those facilities, or not facilities, organizations. And the Living Well in the Community Workshop is a program that was made by people with disabilities to really emphasize peer support and goal setting, to recognize that everyone has a different goal that leads to better health. So how are we working together to ensure that people can get to their health goals? We can't do this without community partnerships. Number one, the University of Montana Rural Institute, and connecting with Meg Tracy, the Centers for Independent Living. As Travis mentioned, there's 4 regional ones across the state. We could talk about our developmental disabilities program at the state and other organizations, DD councils, developmental disability councils, AHEC, the Area Health Education Center at MSU. Really, we could go on and on and on. We work with over 100 partners a year to do this work. And then lastly, our role is to try to get our work to be sustainable. So we can work at the individual level occasionally, but we do want to lead to policy change, system change, and environmental change that makes sure that our communities are accessible and inclusive for generations. And I mentioned those different levels that we approach as it pertains to the socio-ecological model. So we have a program called the Linkage Demonstration Project, which is both individual as well as organizational and interpersonal. Um, we don't often do individual work, but this one we work with people with developmental, intellectual and developmental disabilities to connect them to needed healthcare resources or health promotion resources like pre-diabetes screening or diabetes prevention program, as well as finding an eye doctor or seeing if does your prescription align with your current glasses? And if not, we try to connect them to those resources. And I say this program also works at an interpersonal level because we are partnering with the Developmental Disability Council, uh, group homes, and working as a team to build that peer network and supporting health goals across groups of folks that live together and they can support each other in meeting those goals. There's been a success at the Spring Meadow Resources in Helena where the staff were encouraged to get Fitbits for everyone, and now they have been walking more. They've been encouraging each other to eat healthier and make healthier choices. And it's also um, bled into how the staff approaches health for themselves as well as the people in the group home. And so it's been a really positive experience and shows how we can work on multiple levels. So in addition to individual, we can also talk about interpersonal, which can include provider interactions like decreasing provider bias, as well as person exam rooms, which I have a slide I'll show you next to give an example. Uh, Organizational supports, how can we make our organizations, whether it's affordable housing units, where people will work, recognizing that people with disabilities should be working um, in the places that uh, people without disability are working, and not just thinking of people with disability as clients or consumers, but as employees. How can they be physically accessible? How's the communication accessible? In a healthcare facility, are there adaptive ways that people can fill out forms? Isaac said in the last webinar that because he uses augmented communication, when he calls in to schedule an appointment, sometimes people just shut the phone off right away because it sounds like a robot. But he encourages everyone to wait and hear him out until you know for sure that it's not someone that is just using a different style of communication. Community relationships. We're going to talk today about accessibility ambassadors and how people at the Center for Independent Living can support you in um, doing ADA assessments or walk move audits and addressing environmental changes and barriers. And then public policy and those larger goals that make sure that the work that you're doing is sustainable long term. And next, I said I was show an example of uh, accessibility within a healthcare facility. And because we often think, yep, I can do that, check, check, check. But there really are pieces that are so important to that process. And Megan Tracy, who's on with us today, was the lead author for this article about critical access affordances. And it's talking about entrances to a facility needs to have no steps, or it's called zero entry, as well as power assisted doors or low resistance doors so people can easily open it with little effort. Once you're inside, the interior travel should have continuous and unobstructed hallways. And lastly, in the exam room, there should be clear floor space, leg supports in case people aren't able to be as flexible. Um, so adjustable leg supports, adjustable height of the table so someone can transfer from their wheelchair or if they need to in other ways, get onto the table, and then handrails. Meg, would you like to add anything to what I have shared so far?
This is Meg. Yes, I will just do a shout out to Helen Reset and Holly Haran and also members of our team like Desiree Ware, all graduate students working with us on these projects over the years and now moved on to other roles and spaces, as well as we'll say a little bit more Travis Hoffman, our accessibility ambassadors. Really have this kind of technical expertise and have helped to resource these public health efforts to describe the accessibility of our facilities. So thanks, Mackenzie.
Thank you. So now we'll hop over to talking about accessibility ambassadors. Um, I wanted to share a map of the Centers for Independent Living. As Travis described, there are four. We have North Central Independent Living, and then in the High Line and Central Area, Living Independently for Today and Tomorrow, or LIFT in the blue in the eastern side of the state, Ability Montana in the South Central, and Summit Independent Living in the Northwest. And each center also covers the reservations and tribal communities within that area. So we talked a little bit about what the Centers for Independent Living are in the last one, but as I bring Travis into this conversation, Travis, um, how would you describe a Center for Independent Living and its importance in the community?
Um, so this is Travis. Just going back to your previous slide too with the map, I can send you a new one, but some of the numbers have changed, I think, for Lyft anyways. So I can send you a new map if you like.
Great.
But Centers for Independent Living, I guess the services that we provide are kind of unique in the realm of public health and human services anyways, in that they're peer driven really. We're not here to do something for somebody. We're here to teach people how to do for themselves. We always say you're the best expert on what you need, and we really believe that. So we deliver services based on what we call independent living philosophy, where we try to instill self confidence and honor self determination, where each person really gets to make their own choices. Because a lot of times in the lives of people with disabilities, they haven't always been able to make their own choices, whether they grew up with a disability and always had someone there doing something for them, or they're just new learning the ropes and don't know how they're going to do things after acquiring a disability. So Centers for Independent Living can really step in and be that kind of tool that helps people uh, figure out ways that they can be as independent as possible. Um, on the on the community side of things, we do a lot of advocacy work, trying to pass policies, laws, programs that improve that possibility for people with disabilities to live more independently, to work, to go to school, to go out in their communities, to socialize. And so a big part of that obviously is accessibility. And accessibility goes way beyond the built environment, right? When we all think of accessibility, we always think of, is there a ramp into the store? Is there zero entry? Is there a door opener? Those types of things. But accessibility also includes things like effective communication, providing reasonable accommodation to employees or to people who take part in your services. So I'm assuming that most of the people on this call work for some type of governmental um, entity, whether it be a county, a city, a state. And so there's different requirements for public entities as opposed to private entities. So just making sure everybody knows what they're required to do according to the law, and then trying to get beyond that. What's most usable? Um, Accessibility laws provide the bare minimum of what we should be doing to make sure our programs, services, and built environments are accessible and usable. but sometimes the bare minimum is not very accessible. So, and I think going to your next slide, I guess, with accessibility ambassadors, um, it's really a great program to kind of put people with disabilities in that driver's seat. We always also say nothing about us without us. So getting people with disabilities with that lived experience out there, assessing things, talking to people, making sure that it's not just this is the law and we have to follow it, but this is the right thing to do and how can we do the best we can.
Thanks, Travis. Meg, would you add more to what accessibility ambassadors are?
Um, yeah, this is Meg. I just want to make sure that folks know we put in the chat some of the contact information that is available through the websites for the four centers for independent living. I will say that ambassadors, when we think about partnering with centers for independent living, there are a range of activities that Centers for Independent Living are engaged in terms of promoting access. For our Accessibility Ambassador Program for Public Health, we work with our public health partners and our community planning groups to identify projects where we can resource them with CIL and partnerships and our ambassador activities to drive public health priorities. So um, it is a resource of the independent living movement that we have organized and leveraged into the work of public health, very much with leadership from folks like Mike Mayer and Bob Maffett, Tom Osborne, and some of the work that independent living did very early on to promote access to businesses with supportive organizations like Robert Wood Johnson's Foundation and some of the early work that led to the passage of the ADA. So we continue to try and work with our partners to understand where they're doing, what their capacity and assets are, and really organize with them to resource public health improvement efforts. And it's just been a really wonderful opportunity for us um, to strengthen our partnerships and the public health impacts that we can make by working together.
Thanks, Meg. And Travis, I know you've described a lot about the independent living philosophy and what Centers for Independent Living do. How does the work of an accessibility ambassador break down barriers to better health?
So some of the work that we've done over the years since I've been here is um, we went and assessed, I think, every mammography clinic throughout the state, as well as rural and community health clinics through this program. And a lot of that was not only just assessing, are those places accessible? Is the medical diagnostic equipment accessible? But it was talking with the people who ran those places and um, answering any questions they had, but more so just providing that education on what it means to be accessible, not just in the physical sense, but in the service sense, like as the holistic picture of it all. Is your website accessible? Is the information you're putting out accessible? Do you have the ability to make alternative formats? Do you have the ability to call in an interpreter? Like, how do you best take those accommodation requests and things like that? Just making sure that the people who are providing the services are have that in mind and are able to think through those situations when they arise. Um, a lot of people that we provide services to are lower income and oftentimes on Medicaid. So uh, they sometimes, especially with dental or I've things like that, um, there aren't many providers around, or in the caregiver sense, there's a severe lack of caregivers. But just, I guess, advocating for better policies and better programs and better funding to make those places and those services available to people with disabilities more broadly. I don't know if I answered your question or if that was the answer you're looking for, but
Oh, that's great. Thank you. Meg, anything to add?
I thought that was a great description. I will say, just from a data perspective, when we look at barriers to healthcare, people with disabilities are going to report barriers, just like Travis said, barriers because of cost, barriers because of education needs, transportation. They get a little bit more nuanced and detailed when you really talk with people with disabilities about how to remove those barriers. And a lot of times we collect data just to say what barriers did you experience, and be through our analysis or how we organize our questions. Sometimes we only capture those, and so then we end up sometimes hearing from partners a false conclusion, which is that we didn't hear anything about accessibility barriers from people with disabilities, and it's simply because they didn't have the opportunity to get past some of the major barriers that we all experience. And so for us, I just want to mention that that's a really important thing. The lack of finding doesn't mean it's true, and so just really wanting to center that and say sometimes there are, at the intersectional approach, when you're working with people who may have different reasons for not accessing healthcare, in addition to those related to accessibility needs, and designing for a more accessible environment with people with disabilities. Sometimes you might miss that second piece. So these ambassador projects are in part to collect those environmental and as well as personal perspectives. We've done some convenience samples with people with disabilities just so that they're given the additional opportunity to say, in addition to some of the common barriers to accessing healthcare, what other things do you have to share with us as people with disabilities? And we often get really new information to bring into planning, like with our Cancer Coalition around the mammography project. Um, I will put the updated mammography directory for the state of Montana in the chat for those who are interested. We worked really hard with our partners through the Cancer Coalition to better understand how our mobile clinics work and how to try and represent that better in our directory. So again, just trying to think broadly about access to healthcare and really centering also some of the work that's been left out before on how to address possible barriers with people with disabilities.
Thank you both. Great, great responses. Um, so there are two types of assessments that we wanted to talk about today. One is an ADA assessment, which Travis has a ton of experience with. And the other is an inclusive interdisciplinary walk move audit, which also Travis has experience with. So I'm glad that he was able to jump on today. I do have an example in here of an ADA assessment that our previous presenter was going to talk about, that I wanted to mention, and then ask Travis to give more of his perspective of what ADA assessments are, and what has worked well for him. So, actually, first, I'm going to ask Travis, and then Meg, if you want. What is the difference between an ADA assessment and an interdisciplinary inclusive walk move audit?
so Meg can probably explain the walk audit ins and outs better than I can. But an ADA assessment is, so if we get requested, we can go in and there's specific checklists that are available for different areas of a facility and recreation areas, things like that. But it's a specific checklist based on the 2010 ADA standards for accessible design. And you, depending on where you're evaluating, but basically you go in, start from the outside, go in like through, I think it's 4 different priority areas, starting with parking, or is there accessible parking? Is there accessible route into the building? Is there an accessible entrance? Can from the accessible entrance? Is there a route through the building to where the public would normally go? Things like that. There's a bunch of little details in it, but it's more of a stringent, does the facility meet the the code of what the ADA requires in terms of accessibility? And I just want to mention too, like a lot of times when we talk about access and there might be a barrier, and I've seen this mainly with larger entities, like they don't want to acknowledge it sometimes because they're afraid like, oh, if we acknowledge that we know about it, we're going to get sued about it. And so the way Centers for Independent Living approach ADA assessments is for like we're not there to, to for the gotcha moment, like this is accessible, you have to fix it. We're there to help that business or that entity, whatever we may be doing an assessment, learn what barriers there are so that they can fix it and so they don't face that type of situation. We're there to work with them and not against them. And I think that that's uh, a really great thing with the accessibility ambassadors. And I think that that ties in well to what a walk audit is. And I'll attempt, but Maggie might have to correct me. Walk audits are not quite as stringent. They don't follow a set checklist. But what you do is you get people from who have experience in different areas. Maybe you have engineers, you have business owners, you have uh, moms with small kids who use strollers, you have people with disabilities, you have whoever, like city council people, like, and you you set a predetermined route and you go that because everybody's personal experience in life is different. So everybody's going to experience a route that you travel in a different way, and they're going to notice different things that might make that route uh, appealing or um, not appealing or dangerous or find a barrier. Like even if they point out the same barrier, that barrier may affect them in different ways. So it's a way to kind of gather data on how you can improve a path of travel based on input from very varying perspectives. So
Thanks, Travis. I think that was a very clear way to describe it. Meg, anything you wanted to add?
I would just add from the public health point of view that roles in an ADA assessment for a public health um, organization or a program are, those roles that our University of Montana students often play on our program, which is to organize the checklists into an agenda to review with our accessibility ambassadors. So if, for example, we have the opportunity to support a goal of the Cancer Coalition's plan to make mammography more accessible in the state of Montana, we as public health can bring together our ADA experts like Travis and other colleagues of his across the SIL network and say what checklists are relevant to mammography accessibility. And they'll share the checklist to us. We'll start to organize them into an agenda. We'll start to bring together other partners like from the Cancer Coalition, what other assessment items will be important to include in our statewide approach to describing mammography centers, and we are responsible for convening the partners and reviewing what assessment tools we have and building out the shared assessment tool and standardizing the training that will be used with our ambassadors to go out and do that kind of detailed assessment. And then we helped the partners come back together to organize those findings into public facing documents like the mammography directory, as well into as action plans that go back to the participating centers so that they can be integrating those findings into their transition plans, ADA transition plans, or into their capital improvement plans. But they have those findings to use. And just to underscore what Travis said, we really try and highlight to organizations you're only exposed in terms of legal threats or concerns if you're not doing this work. If you are doing this work, you are aware of the barriers. It is a part of your active planning for barrier removal. That's when you're protected. So we really try and bring that forward with other public health standards that we're trying to promote and resource our partners to meet. So those would be the other things I would add. We'll talk more about the walk move audit, but um, that type of assessment is something that center public health departments that are working on their FABIT accreditation. This is the type of assessment that our public health partners are being asked to do. And I guess as a disability and health program, we just encourage you to take this kind of approach and not doing it on your own, but doing it in partnership with the experts like Travis and our Centers for Independent Living to assess your facility um, and also not miss the opportunity to assess for things that might not be on an ADA Department of Justice checklist. There may be other things that are not in the code but are also important to your partners um, to remove and put into the planning process for community health improvement.
Can I just add one thing?
Yeah.
Um, yeah, so walk assessments or walk audits are also helpful. I mean, Meg, you mentioned that depending on what the goal of the walk audit is, sometimes it's to help put together a transportation plan or to help find the barriers for an improvement project that's going to happen. But sometimes it's making sure, so we have a population of people who are low income, who maybe have disabilities, who maybe their access to healthy living options is limited. And why is that? So a lot of times assessments can also, uh, uh, do people have accessible routes to get to a grocery store where they can get healthy food, where they can get to the health clinic? Are there bus stops? Is it not just walking, things like that? There's options. It's an opportunity to get a holistic picture of those types of things as well to improve health outcomes for people with disabilities and movement and making sure they're able to lead an active lifestyle.
Thank you, Travis. So to show some examples of what this looks like, I wanted to start with an ADA assessment that was done at the Riverstone Health Clinic. No one on this call actually did this, so we are presenting the brief overview of it, but please reach out if you want to know more about this project. But Jed Barton at the Lyft in Billings, Living Independently for Today and Tomorrow, the SIL in Billings, he built a relationship with Riverstone Health um, to do to just start that conversation. Like Meg and Travis were saying, it's about starting those conversations and building a plan, recognizing that no one is perfect today, but if we work together, we can work toward that, toward a fully accessible, fully inclusive, building with accessible communication and strategies and opportunities to recognize that you are always going to have unique support needs being asked for. And so being open to meeting those needs. With that relationship, they applied for and received a grant from NACCHO, or the Health and Disability Work Group from the National City and County Health Officials. They then completed an ADA assessment of Riverstone Health's clinic. So, as Travis was describing, it is the checklist of the 2010 ADA standards, where Jed and maybe another team member goes around with the Riverstone Health staff and identifies, and then maybe they do it by themselves, and then they have a conversation with the staff later to talk about what came up. Um, and the goal is to do this together, not to gotcha, but to really identify those barriers together. So they analyzed the results and presented the results to the staff in a lunch and learn presentation. They then realized that Riverstone Health would benefit from a disability inclusion committee. So this is one of those policy changes that I was talking about earlier that ensures that it's not just a one and done, but there's a committee that is looking at the facility and looking at communication strategies and future policies consistently. Um, over a long period of time. This is the type of committee that can help create that plan, build accessibility planning into the current structural planning for the facility. And then other specific environmental changes that came from this ADA assessment included a drive-up security drop box for clients to drop off paperwork or payments without having to go into the building. They put in this concrete slab with this high security drop box. There are steps to it, but also you can just drive straight up to the curb. They changed the way the automatic door works. So in the picture that's shown here, the button to open the automatic door is on the door. So when you roll up or walk up and you press that button, the door comes right open into your face or into your chair and then goes back and gets shut again. So it's really ineffective. So what happened is they recognized a better place for it would be on the left side of the door completely. So someone can roll up or walk up, press the button, and then the right door will open up and it's an easy access into the building. I also have a picture of the actual button on the right side. And then another change was a wheelchair accessible scale. Um, When facilities don't have accessible scales, people go without being weighed, and so they are unable to assess certain health metrics, or their dignity is tested and they are asked to go to a grocery store or a meat packing facility, and that is not appropriate at all. So accessible scales can be very respectful and useful and really help people long term with assessing their health. Uh, Travis, is there any ADA assessment that you wanted to describe, something that had a positive impact in your community?
Oh boy. It's been a while since we've done one. Not that I can think of off the top of my head.
That's okay. We'll move forward with the I2 audits. Um, so the inclusive interdisciplinary walk move audits, as both Travis and Meg were talking about earlier, it's about bringing community together through the whole process. Like, if you ever get a chance to participate in one, it is eye-opening. I got to do it my first week on this job and learned so much from each of the folks on the walk move audit that were able to share their experience. So I will let Meg explain how this works.
Thank you, Mackenzie. I do really appreciate the comment in the chat. I wondered if you could read that first and then I'll.
Sure. So Deanna Rumsey wrote, for medication titration, accessible scales are critical. Otherwise, providers are guessing weights and prescribing meds accordingly. Yikes. Ooh.
Great call out. Yes. Weighing in and having accurate weights for so many reasons is part of our medical care standards. And many people who are wheelchair users um, don't have that standard met in their healthcare. So yeah, appreciate that. Um, I will say, so the walk move audits is a term that we use. Sometimes I just want to say, just like with person first language, if your positionality is not as a person with a disability, I recommend using inclusive interdisciplinary walk move audits when we talk about this approach. You may hear some people who equate walking to moving and being a wheelchair user, that's their prerogative. But if that's not your positionality, an inclusive term that we come to is walk move audit. And when we think about a full implementation of this approach, and it's a continuation of supports, right? It's a continuum of supports, I should say. The full walk, move, audit workshop is something that we adopted in Montana and is a 3 to 4 hour event. It begins with a presentation where the different perspectives on an interdisciplinary team can be brought forward as the rationale for doing the public engagement process. So the presentation reflects the priorities of the city or town or area, even a state park, and really provides the opportunity to say, here's the opportunity we have right now to make change. We can be working on a policy, a project, a program, some systems changes, in benefit oftentimes of the economic vitality and the vibrancy of a community. And city engineers and planners often will share that opportunity in this presentation. A unique perspective that has been added through CDC's investment in this approach is a public health perspective. So, in addition to what a city planner, an engineer, leadership of the city or town, the jurisdiction might bring forward, can be underpinned with public health priorities. So, having the public health perspective, the data, why do we do this work? Why are we really promoting active transportation as part of the vibrancy and economic uh, uh, vitality of a community? And then why does this work also help us all live healthy lives in this community? So public health will present their data and share how important it is to have active transportation opportunities for incidental physical activity, accessing social connectedness, and healthy foods. So that's the first part of the presentation. It really helps to bring forward that perspective. And as we've adopted this with disability partners and expanded the interdisciplinary perspective to say, the disability community has a lot to say about how we plan our communities for aging in place, and also for, disability friendly communities, so people can move in and out of their daily lives if they have functional limitations, short term or long term, or their family and friends do. So just that's a presentation. And so we will bring forward those perspectives in a full workshop of a walk move audit. Next slide. Um, this photo is from part 2. There's a lot of work that goes into planning the route then, so that people have the opportunity to move through the routes in the community or jurisdiction area, and really explore together how an environment supports or doesn't support um, the togetherness, the access to resources, and that work is done by this interdisciplinary team. That through the walk move approach, we've really expanded again to be like city planners, city engineers, public health, and somebody with expertise representing the disability community or other marginalized groups. I'm really bringing that team together to say, how do we plan a route that will allow for shared discovery of the public and of decision makers, the good, the bad, and the ugly, a route that will cover things that are really exemplary that we want to be promoting, and the opportunity we have to be formulating policy, projects, program changes, systems changes. What are things that are fine, adequate, that we want to protect, and or maybe improve in our opportunities, and or the things that are ugly that we really need to prioritize for immediate action through the opportunities we have as a group. So the team will plan, starting probably a month or longer ahead of time, what route they'll choose to take people on after the workshop presentation. And I'm happy to share more about that and how that works. Um, but I really encourage you to get involved in that. It usually is anywhere from 1 to 4 miles for being really something that we plan for people to return back to the workshop location If that route is too demanding and have a virtual option so they can be going through photos of the planned route together, that can be what we call an alternative format or an option for people. They may stay back for the whole time, just depending on their preferences and the energy they have to be engaged in something like exploring the route together. So, on the route, there will be stops planned, and together we use a motivational interviewing kind of tool, which is to just ask people on a scale of 1 to 10 to rate their experience. And part of the workshop is that you train people to make those estimates using 4 decision criteria, and those elements are really um, what do we want in terms of supporting active transportation? What do we want in a community, and how we've organized resources to be laid out and networked to access through those active transportation routes. So um, we train people on those 4 elements, and then along the route, they're able to score things on a 0 to 10 scale. 10 being like, we loved it. This is the best thing we've ever seen. 0 is the worst. And then just like motivational interviewing, there's no right or wrong answer. We're just gauging where everyone is at. And then we're exploring why scores are higher, why are they lower, and we're learning together through shared discovery, um, you know, where we are sharing and have common uh, needs for supports, and where we might have some differences. And then we are able to learn more about one another and our community and come together into um, a space for better planning on the policy projects, systems change, environmental changes, opportunities we might have. So here's a photo of Mark Fenton in downtown Billings, and he's asking the group to give their scores. Shout them out, 0 to 10. And we've done a lot of work to try and figure out how to make this process inclusive of people who are deaf, people who are hard of hearing, people who are blind and low vision. I'm happy to share some of those accommodations and supports we've learned about from our partners representing those communities to be engaged in this kind of shared discovery moment on the Walk Move audit. So an example of shared discovery that we often are planning for in our routes is there's a lot of ugly sometimes, depending on seasons, depending on the routes that we're going on. And we know that one of the elements, which is accessibility and safety, and also an element of site design, that the whole process of being together can be bogged down by things that are really hard for people who have not witnessed the difficulty and the barriers that people with disabilities experience. We can really move from a process of shared discovery and the opportunity to be working on the big project or policy changes into quickly, it can dissolve and devolve into a disability sensitivity training. And we work really hard to say that's not what this is about. The people with a disability who are on this event are not here to do that training. If you want that training, you can pay for that training, but they are here just like you to be a part of this process. And so on the route, we've really learned to say, okay, there are going to be spots where we really teach to some of those challenges that are everywhere and experienced by people with disabilities, and just create a moment for education that is purposeful and represented by the team, usually the person representing the disability organization, but we work really hard to organize so that we stay together as a community and that we're working on those big issues as well as integrating the accessibility issues that people with disabilities confront. So here on the left, there's a sidewalk and a person with a wheelchair navigating to a bus stop where it's unclear how they will get on the bus. And but it is a continuous sidewalk. Um, there's a post for an accessible parking spot on street parking. There's a mailbox, and the person with a disability using the wheelchair is going to navigate around those things on this sidewalk. Somebody who is blind or low vision might have more difficulty anticipating where those barriers are. Travis, anything that you would add for that photo?
No, I think you covered it. Yeah, just maintaining accessible features is just as important as having them and putting them in. You can have a ramp, but if it's a place where bicycles are chained up to, or there's a branch going across it, it just makes it unusable. So just making sure that maintaining the usability of accessible features is an important aspect of making sure you're accessible.
Great. And with the time we have, I'll just mention on the right, it's a photo of a curb cut with the truncated yellow domes going over a piano keyed crosswalk that really evidences the crowning that results from long-term maintenance of roads and creates a divot where there's a lot of pooling of debris, water, snow, and can be a challenge that we observe on these walk move audits and goes into planning for city maintenance and public works.
We have about a minute, Meg, to describe part
Yeah.
three.
Part three is where we come back together and do that important planning for those projects, policies, systems, and environmental changes programs as well. And really trying to take that public health approach of sustainability. Our efforts need to be short-term demonstrations of what might work, learning from that, and putting that into those multi-level planning efforts. And so this photo is Mark Fenton in Billings at the Montana Association of Planners Conference, facilitating this part of the Walk Move workshop.
Thank you,
And so,
Meg.
yep.
So I'm gonna have Erin close us out with some call to action and a short opportunity for reflections or questions. Erin.
Yeah, thanks, Mackenzie. This is Erin. So, what can you do next? So, we've talked a lot about different things that can be implemented, but prioritize your training staff. We are here as a resource as well, and please reach out. We will send Anna our contact information as well as some other resources that we wanted to use to support what we've talked about both the last session and this session today. So, making sure that you are asking those disability demographic questions and surveys and intake forms. That is really important. Finding out more and see how you can collaborate between those things. So maybe identify support needs of partners. Again, we're happy to be a partner. Reach out. We have partners in different areas of Montana and can help facilitate that conversation. Work with participants. So, as Travis and Meg and Mackenzie mentioned, working with all participants and meeting them where they were at and getting their lived experience to add value to the conversation. So, and working with clients to assure needed accommodations are provided, and then build that relationship with your local center for independent living. They're a great resource and can be a very big help in helping you achieve what you wanted to next in your call to action. Maybe develop a committee to facilitate and sustain long-term accessibility planning. Maybe trying to implement an ADA assessment or an I2 audit. Again, please reach out. We're happy to help with that. And then make changes that address those barriers. They don't all need to be large changes. They can be just small changes to access and address those barriers, and then to meet the needs of people with disabilities. And I know we're at time, so I don't know if we have time for questions, but again, let us know. We're happy to help. Again, we'll send the backup resources and to Anna, and then as well as our contact information was in the PDF that Anna shared in the chat.
Well, thanks so much to our presenters. We'll stick around for a couple moments if anyone has any questions, and we'll again be sure to share their slide deck and contact information following should you have additional questions. But just want to thank you all for your time. Thanks for joining. If you are pressed for time and need to hop off, please feel free to do so. And then if you do have any questions that you'd like to ask now, please go ahead and ask them. I see a couple in the chat here. A lot of thank yous. Oh,
This is
number 8, they want
Mackenzie.
to see.
Number
Yeah,
8
thanks.
was include people with disability as a priority population in community health needs assessment and health benefits planning. Um, so making sure that when you are working on your CHA or your CHIP, that people with disability are included in that planning process and that their voices might be weighted in the conversation and that there are disability priorities and objectives that are included. And I think Meg, if you have more questions about that, Julie, I don't know if you're still on, Meg has worked in Missoula with the Missoula Public Health Department on developing a strategy around independent living um, as a public health necessity to be a part of their community health assessment. So she'd be open to talking to you more about that.
Yes, it's Meg. I would just quickly add framing disability as a population and a set of partners within your chip as opposed to something to be addressed and prevented. So trying to really be a part of that paradigm shift from disability as part of morbidity and mortality to that disability is a natural part of the human experience and it is a part of your community. And there are people who represent that lived experience to bring into the chip.
And I'll draw attention just to one quick question in the chat. Since advocacy is one of the core services of a CIL, what are some of the biggest challenges with advocating for environmental accessibility? And are there tips that we have found useful here in Montana?
This is Travis. Um, I think some of the biggest challenges are, well, one of the biggest is funding, obviously. Um, the no place is grandfathered in. Everybody has to work towards accessibility, and all new construction has to be constructed accessible. But when it comes to like older buildings and stuff, it doesn't happen so much anymore as it used to. But kind of the mentality is, I don't have anybody with a wheelchair that comes here. Why do I have to put in a ramp? So things like that have been barriers, but I would say funding is a big one. Also, oftentimes, and I don't know where the responsibility lies, but like uh, people are allowed to go into business or open a business or whatever without having that accessibility checked thoroughly enough. Um, and then also just being in Montana, because we track accessibility across many different things, not just accessibility of government services and businesses, but housing and transportation and sidewalks and all those types of things. And so in mountains anyways, some areas are really steep and that provides a challenge to providing good, adequate accessibility. Some of the rules around the construction of building accessible homes or accessible housing only applies to fourplexes or bigger. So making sure that people can, or that developers are incorporating accessibility into housing things or housing developments is a huge challenge. And how do you incentivize them to do more? Because changing building codes is near impossible, and local building codes can't be more stringent than state building codes. And yeah, so it's a there's a lot of advocacy out there to be done. So
One thing I would add is that as public health has gotten more involved with social determinants of health, is to really think about accessibility from the disability perspective across social determinants of health and to layer it into that. I don't think we've always had the opportunity in public health to be looking at the environmental side of the equation, when we're thinking about chronic disease prevention and health and wellness. Some other areas for sure, critically looking at the environment, but in our efforts to look at social determinants of health, really be working with centers and accessibility and their advocacy in that new framing of our opportunities to strengthen health outcomes with our communities.
Send a comment. Feels like a great opportunity to partner with urban planners and folks working in the digital information space. Absolutely. Well, we're a few minutes past time, so I want to thank everyone again. Thank you for joining today. Thanks for this great information. I will send recording links back out as well as post them to our website, as well as the documents and resources that the team has shared today. And we look forward to future learning with you all. Thank you so much.